Welcome everyone to another podcast. And this one is going to be very specific today. It's going to be all about orthostatic intolerance, essentially problems with being upright versus lying down. And there are two main ways of which this can be the case: orthostatic hypotension and Postural Orthostatic Tachycardia syndrome. I'm going to put more emphasis on the latter, POTS, because it appears to be more prevalent. And also, it appears to be one of those things that is more debilitating. And as I'm working on this today, I want to talk about a couple of papers. I'm going to start with a paper by Raj and Fedorowski and Sheldon, 2022, Canadian Medical Association Journal. And I'm going to use this as a reference point to discuss how medicine looks at POTS, and I think it's a good paper for that. There are probably other caveats to this beyond the paper, and those are in other, consensus statements and things like that, depending on which country you're in. But generally, you'll find what I'm about to talk about is what the mainstream medical associations and doctors believe. So, and I want to give my slant on it as well and give an alternative perspective, particularly for cases that are not responding to the medical model that is being used currently. So, some key points that the paper states, and this paper is called Diagnosis and Management, POTS. POTS is a chronic multi-system disorder. The cardinal feature is orthostatic tachycardia. In other words, upright tachycardia. Patients with POTS have symptoms of orthostatic intolerance that improve with recumbence. And also, that's another word for lying down. When we work through this today, the key here is to make it very clear what POTS is and what it's not. All right, and a lot of people, unfortunately, have been misdiagnosed as POTS, and therefore, because they haven't had the proper rigorous examination and diagnosis procedure, they are lumped in with a whole bunch of people who have different underlying features. All right, so just be aware of that as we're going along. There is a female predominance within POTS, and it tends to begin, POTS that is, in puberty through early adulthood, say early 20s. This is when it tends to start to come on. POTS can lead to a marked functional disability, often limiting work and schooling. This is the case. Many people are unable to stand up for long periods of time. There are extremes, and then there are lower end of the spectrum cases. And sometimes they don't express the same way. So in some cases, the dizziness component, which is classic of POTS, is actually marked by headaches or weird sensations that are unexplained. Now, let's have a look at what they say. Now, the main characteristics of POTS is tachycardia with standing, without a drop in blood pressure. Now, this is critical because many people don't assess their blood pressure when they're examining POTS. Patients describe lightheadedness, palpitations. This is where they feel their heart rate beating upon standing. And upon standing, what you should find is that there is the sense of lightheadedness and the palpitations, as already mentioned, dizziness, that kind of thing. Now, the syndrome is more common in women. Now, that may be because of a hormonal thing or something to do with women that men don't have. And one of the things that often comes up, which is definitely of note, is ehlers-danlos syndrome and hypermobility syndrome, because relatively the same percentage of people who have POTS, 70 to 80% are female. 70 to 80% of people with ehlers-danlos are female. Now, that might be just circumstantial evidence, but we also know that at least 50 to 60% of people with EDS or hypermobility syndrome, this is in some studies, mind you, it's hard to say how widespread it is, that percentage of those people have POTS. So it's high. It's a high percentage of EDS cases, ehlers-danlos syndrome, which is a high mobility syndrome type, associated with, well, proposed to be associated with collagen. I have a different theory on that, but those are definitely related to this condition. And many people out there who are experiencing POTS will more than likely have EDS and or high mobility spectrum disorder. So we're going to look at the definitions and what it is to be diagnosed. So here's the criteria. It's very important that if you've got POTS that you meet this criteria. Otherwise, you might find that you've been incorrectly diagnosed. So let's talk about that. You must have all of the following criteria met. A sustained heart rate increase above 30 beats a minute or 40 if you're aged 12 to 19 years. Okay, very important. Within 10 minutes of upright posture. So you're lying down, you get a resting heart rate exam, then you stand up. Within those 10 minutes, if there's an increase in the beats without any talking, without any other activity, just standing there, then that's a tick. 30 beats plus. 29 is a borderline mark, but you can count that as a yes too. Absence of significant orthostatic hypertension. So a magnitude drop of 10 or 20 milligrams per milligrams of mercury. So 20 in the systolic and 10 in the diastolic. Now, if you have that, you more than likely have orthostatic hypotension rather than POTS. And that's often the case. Like a lot of people who will say, I've got POTS, but I've got low blood pressure. I'm like, I think maybe you've been misdiagnosed. Because you've got to remember that POTS has a tendency towards being hyperadrenergic. In other words, sympathetically driven, although there are some errors in that statement, and I'll get to that. And so these cases many times are misdiagnosed, and really they are hypotensive. Very frequent symptoms of orthostatic intolerance that are worse while upright. There's another factor you need to have ticked. With rapid improvement upon return to a supine, lying on your back position. Symptoms vary between individuals, but are often including lightheadedness, palpitations, a tremor feeling, generalized weakness, and blurred vision and fatigue. Fatigue is a very classic symptom in POTS, as the body is pretty much getting tired from being upright. Symptom duration has to be more than 3 months. Prior to that, it may be just a transient event. And an absence of other conditions that could explain the tachycardia. Okay, so it's really important that we have had these checked off. If we don't, we cannot diagnose POTS. So if you have acute hypovolemia, so this is from dehydration or blood loss, and a lot of people do, and they still get diagnosed with POTS. The problem is that is very different. That is a lack of blood, and you cannot have appropriate blood pressure and heart rate when you have a lack of blood. Anemia is another cause, and that's again to do with a lack of oxygenated blood. Orthostatic hypotension, low blood pressure related upon standing. A variety of different types of endocrine disorders can cause this that are not actually POTS. So one is called adrenal insufficiency, and that relates directly to some disease of the adrenal glands. Okay, whether it be autoimmune or other diseases that might be there. There's certain tumors that can cause this, and hyperthyroidism is another one that can cause it. There can be adverse effects from medication. So look up all the different associated side effects of your medication. They might be tachycardia, high blood pressure. They might even say orthostatic intolerance, dizziness and lightheadedness. If that's listed, it may be the case that your medication is causing it. If someone has got panic attacks and severe anxiety, this is enough to cause POTS. So that condition of anxiety is another thing that needs to be ruled out, because it is a brain-derived disorder associated often with stress, and has got a lot to we have a lot to talk about with anxiety and POTS, because there is a commonality between both, and that's the vagus nerve and the autonomic nervous system more broadly. And it might be the case that you need to not call it POTS, but just call it vagus nerve dysfunction, because the anxiety and the POTS-like symptoms are all related, can be all related to the vagus nerve or a dysfunction in the sympathetic nervous system too. Prolonged or sustained bed rest. If you've had that, you're going to be intolerant anyway to standing upright, and that's deconditioning type. Be aware that all of these things, many people disagree. This is the problem with the industry. But generally, if you have these are not POTS diagnoses. So as soon as you have one of these, it's likely that you don't have POTS. Recreational drug effects. So if you have in the past or previous to relatively close to the onset time, is useful, because then you can tag the two together. Recreational drug use may be a precursor to it, and that might be due to some kind of damage to the nervous system. It might be its effect on the heart and the blood. So be aware of that as well. Now, a lot of people will say that it's to do with this process of blood pooling. Now, that's not completely accurate, because that is only really noted by certain types of testing in the lower body. And it seems to be the case, but in most studies, I would say it's 50% of the cases have that. And again, that state is attributed to small fiber neuropathy. And those small fibers are the fibers that are going to the blood vessels, and they're sympathetic nerves. So they're part of our fight or flight system. And they're noted in these people as being in the lower body predominantly affected. And in the periphery, not just the lower body, but mostly in the periphery. So the hands, the feet, and the legs. Or they can be also in the trunk, but the trunk is already quite well dilated anyway. The lower body is different. And a lot of these concepts are just, that's how they explain it. POTS is due to that pooling, but there is so much more to it, and I'll explain that today a bit more. So there's other things that tend to come with it, things like headaches, chronic fatigue syndrome. I mentioned EDS and hypermobility. There's other autoimmune diseases often with that. Mast cell activation syndrome. A lot of people have celiac disease, which is autoimmune, and fibromyalgia. And I personally have an explanation for all of that. A lot of these conditions are attributed to a problem with the autonomic nervous system. And the autonomic nervous system is particularly susceptible to damage. And that's something that I will explain in a moment. So let's talk about the main things that they think affects POTS. So the theories around it tend towards, I'll get to that now. This is from another paper by Zhao and Tran, 2023, POTS. It's on POTS. There are 5 main reasons they say someone has POTS. Mind you, these are very theoretical and hypothetical, actually. One is the neuropathic cause. So this is actually a little bit more in line with my view that there is nerve damage. And that nerve damage, the small fiber nerve damage, it's more than the small fiber nerve damage, I can tell you now, leads to an aberration in the way that the blood vessels behave upon standing. So they don't constrict. But it's also noted that there is a definitive drop in noradrenaline, in these nerve pathways. There are other reasons for this than nerve damage. You can still have nerve damage, okay? But you can also have autonomic changes at a central level. For example, if you have a condition I call hyposympathetic dysautonomia, low sympathetic tone, you can get this condition where the lower body does not have sufficient sympathetic activity. And therefore, you're going to get a range of symptoms associated with that. That can be the blood pooling, because the sympathetic nervous system stops blood pooling in the legs. It can also result in a bluish tone, a sort of dusky tone in the legs and feet, and this is blood pooling for sure. Pins and needles can come about with that, and aberrations in perception in the lower body. The other belief is that it's due to an hyperadrenergic response, so increased levels of adrenaline. Now, that one is true as well. And I've found that, how is it possible that a bunch of them have hyperadrenergic, increased adrenaline, and then a bunch have reduced, decreased norepinephrine or noradrenaline? It's the same substance. Now, the only explanation that I would say that a good explanation is that what state could cause both? Well, let me tell you. Vagus nerve dysfunction and damage can cause both, and here's why. When you cause, and remember, the vagus nerve is unusual, okay, because it is one pathway. Mind you, there are multiple portions of it. One pathway, just from the brain down, that, if impeded, has systemic effects. Whereas the sympathetic nervous system doesn't work that way, because the sympathetic nervous system not only has got nerve supply to blood vessels, it's got blood supply with adrenaline. So this is where I don't think it quite works, their belief system, common belief, because when you have a sympathetic response, you get adrenaline in the blood, or epinephrine, which is the same substance. And that also causes blood vessel change. And there's also a neurological component to that, not hormonal, which is what I just mentioned. And that is when the nerve endings, those small fibers, come from the sympathetic nervous system by way of other nerves. They go through other nerve pathways like median, tibial, fibular nerve, and so on. And they get into those blood vessels and they dilate them there or constrict them. Either way, depending on what the situation is. And so adrenaline does that, but so does noradrenaline. And so if noradrenaline nerves are not working, then you still have adrenaline. So why isn't that working? And that might take a bit longer, but these people get worse upon standing. Longer they stand. So by then you should have had an adrenaline response. But it's clear that they have less. Okay. So there is cases where there is less and then there's more. So what could cause both? Well, once you have vagus nerve dysfunction or disease or blocking, you can get an inhibition or an excitation of the opposing system or the same system. Now, when you're dealing with autonomic nervous system, you're dealing with two sides of a coin. One side is the parasympathetic, the other side is the sympathetic. Now, this is a simplification, but it works for POTS. When one side is more active and facing the front, very active, the other side is inhibited somewhat. And there are cases where, with the vagus nerve being compressed, it can go in full position of facing the front. In other words, the vagus nerve becomes hyperactive. And then there are cases where, when the compression causes hypoactivity, reduced activity, and it flips the other way, and you get increased adrenaline, increased sympathetic outflow. You definitely see these in cases. We know that when nerves get damaged or compressed, they can become hyperactive or underactive. And that's the case for POTS. So for the cases where there is blood pooling, you're getting a lot of that due to, from my perspective, an increase in vagal activity. Not a decrease, but an increase. And that huge amount of blood flow in the periphery and pooling is that there is a sort of an inhibition of the sympathetic nervous system by way of the vagus nerve. And this is called a hypervagotonic state, and it's associated with many other symptoms. And I've mentioned these in many of my posts, so we're going to talk about these two states. But the other side of the coin that might happen in some POTS cases is actually hypovagotonic states. And that's where the vagus nerve becomes underactive and is less responsive to the upright posture. See, when you stand upright, you have these things called baroreceptors or pressure receptors in your blood vessels, and the increase in blood pressure upon standing is very well noted in these receptors. And those receptors go, ooh, an increase in blood pressure. And there's a decrease in the blood pressure of the brain, all right, because the brain, the pressure is going down away from the brain. So we need to increase it. So the blood pressure increases because it needs to get the blood to the brain and to the upper body more. But the brain primarily, that's where that really matters. And then it goes up, and then it's achieved its goal. But sometimes the vagus nerve just doesn't respond. It doesn't respond to the excessive blood pressure and excessive heart rate. And it can tell that's its job when the heart rate is going too high and is sustaining for too long. Same with the blood pressure. So it brings it down again. And that's the appropriate response. But when the vagus nerve is underactive, it doesn't do that. So you get POTS. That's the hypovagotonic POTS. Then there's the other one, hypervagotonic POTS, where the vagus nerve is compressed too, but it's hyperactive. So when you stand up, the sympathetic nervous system tries to activate, and it does in the upper body here, but it misses the boat in the lower body. And because there are many other factors when it comes to the development of a higher heart rate, you're going to get this huge blood pooling, and it becomes the most important thing. It becomes more important to get that blood out of those legs, but it can't. And it can't get the blood into the brain. So it ramps that heart rate up to draw the blood back to the heart. Yeah. And try to get it into the brain as well. And it can't do that. So it keeps going up and up and up and up. In these cases, they have a tendency towards having other symptoms that I would consider hypervagal. So this is how you know. So let's discuss this hypervagal state. So on my Instagram, I constantly post about these different styles, but let's talk about the type. So you might find with a lot of these cases there's some confusion. Now, the reason there's confusion is that a lot of POTS cases have bradycardia. They have low heart rate. And circumstantially, they have very, very high heart rate. And the blood pooling. And this is where the confusion goes. So how is it possible to have both? Well, there's obviously some fail-safes in the system that allow for the tachycardia to emerge even with such high levels of vagal activity. And we don't have all the answers, but it's very clear that it's vagal because I've had numerous cases of this where I treat the vagus nerve and stabilize the vagal pathway and return it to normal function. And that blood pooling doesn't exist anymore. It doesn't happen anymore. For small fiber neuropathy or not, it seems to not matter. So let's talk about these two states because they're really important. So one is called hypervagotonia. That's what I've mentioned already. And they'll often have a bunch of these other symptoms. So these are the ones that are definitively one or the other. Bloating and constipation is definitively hypovagal. Difficulty swallowing and problems with speech can be either or, okay, for different reasons. And look on my posts for this. Tachycardia on a day-to-day basis. So people have a tendency to have higher heart rate all the time. And blood pressure or blood pressure, not necessarily both, and arrhythmias. So they have additional beats in their heart rate. They might also have AF, atrial fibrillation, And both types can get fatigue for different reasons. But one of the things I look for is that constant tachycardia and constant high blood pressure. That's definitely hypovagal. And the bloating and constipation, again, hypovagal. The difference is that hypervagal have constant or intermittent nausea and need to vomit. They have a tendency towards diarrhea and stomach cramping. Very different. And they often will have bradycardia, in other words, very low heart rate, sub or mid 50s or below 50. Although that may not be bradycardia specifically, it's on the lower end. And they also have low blood pressure, not high. Okay, so those are the specific differences between the types. Mind you, hypervagal people have a tendency towards having postural hypotension, not POTS. So there are these subcategories that just sort of fit into their own, yeah, and that's why it gets confusing. But the key here is understanding that it all really does stem from the vagus nerve, from my perspective. And at the moment, what's happening in the medical world is that they're treating symptoms. So they treat the high heart rate for the POTS, but actually many of those cases are hypervagal, and that medication makes them further hypervagal, but stops the high heart rate. So it can exacerbate the nausea, it can exacerbate the gut issues and things like that. So it's a bit troubling, and the key is to treat the cause, not the symptoms. Another thing I'd like to talk about is this small fiber neuropathy, because small fiber neuropathy is critical to understand, because it's obviously there in these people. And there's some really important things about small fiber neuropathy you've got to understand. One is that the same reasons that you might have small fiber neuropathy could also be the same reasons why you have vagus nerve neuropathy, vagus nerve damage. They're all susceptible. They've all got these fiber types that haven't got so much myelin. They're more susceptible because they're the ones in the throat and in the heart valves and things like that are more closely linked to toxin exposure. So if you've got things like small fiber neuropathy in the periphery, it tends to be something in your blood that is going to be present there, not that something you've breathed in directly affecting it, or something that you've swallowed. You might have swallowed a toxin or breathed in a toxin and got into your blood, and then that's when it can affect you. Okay, so let's go through some of these things that are known to cause small fiber neuropathy. All right, be aware that many people will tell you that it's potentially autoimmune, or that it's viral or parasitic. This is very much based off circumstantial evidence that people have symptoms of both, so they attribute it to it, but the evidence is very poor. There's far more evidence of the following, that they are small fiber neuropathy inducing because they are known neurotoxins. Okay, so let me get to that now, and we're going to discuss them. So I've got a post on small fiber neuropathy on my Wellness Collective, and this is some of the content from that. So to diagnose small fiber neuropathy, remember, this is one of the main reasons they believe people have POTS. You can do it through skin biopsy. So you take some of the nerve and essentially look for any density changes in it. You can do quantitative sensory testing and autonomic functional test as well. But these are not necessarily indicative of small fiber neuropathy more broadly. They look at it at a specific local level, and it's not unlikely that many people who are healthy without these symptoms have this as well. But let's just say that it is the cause, and let's just say we've got to figure out why. Okay, well, toxicity is more than likely the reason. Now, I must preface this with, if you have a vagus nerve problem, you will have a detox problem, because the vagus nerve is the primary nervous system component of detoxification. Without it, your detoxification rate dramatically drops down, because you've got poor detection and poor isolation of toxins. Your liver is also innervated by the vagus nerve, so liver function is severely affected by poor vagal function, not to mention the kidneys and the gut. So all of these things are involved in detox, right? So if I say one of these things, you may say, how on earth would I get exposed to that? Well, you may not have got exposed to a lot, but over a long period of time, you did. And with poor detoxification capabilities due to low vagal tone or poor vagal activity, this may have happened much more readily. So one is called acrylamide. Acrylamide is used in industry, but it may actually be found in other things such as water, drinking water, and hexane. That tends to be used in textile manufacturing and in glues. Unlikely that people have been exposed to these two, but you never know. It's possible. Organophosphates. Now, organophosphates are probably going to be one of the most likely causative agents. And organophosphates are everywhere. They're not just in your sprayed veggies. They're actually being sprayed on planes now because of mold. So they use organophosphate sprays on planes every time they land. They respray. And sometimes when you go into a plane, you'll see something falling from the air vents, this kind of spray in the air. That's organophosphates. So that's another way to get exposed. And when you go to parks, a lot of the council are spraying organophosphates on the grass and into the garden beds. Heavy metals, so arsenic, lead, mercury, the classic three. There's also cadmium and thallium, all of which we get exposed to. So arsenic, lead, mercury, cadmium, plus thallium, plus probably aluminium to a certain extent. Silver is getting more prevalent because it's used in cloud seeding. There's no debating that. That is the predominant use of silver in the atmosphere, silver iodide. And silver iodide is getting linked with neurotoxicity now. So there's lots of things that can cause it. Let's talk about some of the drugs. So chemotherapy, famous for causing nerve damage. So chemotherapy drugs and a lot of the newer versions as well. Antiretroviral drugs, often used in treatment of AIDS, but other antiviral drugs as well. And the more we learn, the more we find out that these antiviral drugs are actually quite harmful. A lot of antibiotics have been linked to neurotoxicity, peripheral neuropathy, small fiber damage. So just be aware that if you've had a large dose of certain types of antibiotics, it might be the cause. Statins have an association with neuropathy now because they block cholesterol. Cholesterol is required for repair of nerves. So a lot of people don't like cholesterol. They think it's bad, but the truth is without cholesterol, we get all sorts of problems, including poor production of hormones, cholesterol-based hormones such as cortisol, cortisone, testosterone, estrogen, etc. And if we don't have it, we also can't have adequate myelin and nerve repair. So metformin has now been linked to lower B12, vitamin B12. And so use of metformin could lead to small fiber neuropathy due to B12 deficiency. There are other chemotherapeutic immunomodulators that are used alongside, so that might be another one. And of course, alcohol. So alcohol consumption and drugs. There's other drugs as well, but we're not well studied, unfortunately. But you can imagine any kind of drug that's been linked to brain damage, like crystal meth, I can assure you will cause small fiber neuropathy. Alcohol is one of the worst drugs for small fiber neuropathy development. And it happens over years of alcohol consumption, excessive alcohol consumption. And if someone has poor detox ability, then you'll probably find that they're far more likely to get that as well. So there are lots of reasons. So let's discuss what some of the solutions are. So with a lot of these cases, it's important that we start living healthy. I've always said this thing called slang, but basically slang is all about getting the things you need from the environment, not from drugs. Okay. So, firstly, I won't go through that so much, but I'll just mention the key things. So, the key things for health and recovery are going to be light exposure, sunlight. You need to get sunlight exposure every day directly to your body and not with any sunglasses. This is going to increase your autonomic function. Is well proven in the literature now that sunlight exposure is the more sunlight exposure you have, the less likely you are to get cancer. Look up all the papers that are coming out. Now I've found that UVB, so-called bad radiation, tends to be actually associated with a reduction in cancer and in systemic diseases. And it's, I think, linked to better autonomic function. Another one is just being in nature. The more time we spend outdoors and in nature, particularly, the better our vagal tone. It's been found in numerous studies that outdoor exposure is linked to higher heart rate variability and lower heart rate in general. So normal heart rate. Critical. Clean water. Clean water is everything because a lot of our toxins come through our water. So I personally I distill my water and make sure I have enough salt in the diet to make sure I don't get any mineral deficiencies from not drinking enough mineralized water. That's how I reduce my risk there. Clean air is important as well, but we can't always decide how clean our air is. But I wouldn't exercise in an urban environment. Make sure you exercise either in an area where they've got some kind of air purifier indoors, or go and exercise in nature. The other one I wanted to mention is connection. People feel alone, are far more who are alone, live their life alone and don't have any good connections, no friends, no family, no love in their life in general, are far more likely to develop severe disease. And you see this in studies as well. That's heavily associated with poor heart rate variability and autonomic problems as well. So a lot of people can do all the great things. They go outdoors every day, they eat perfectly, lots of good protein sources, good fats, lots of fruit, all the right things, but they just don't have any connections and they don't have good relationships around them. And that can be critical with recovery. But the other things that beyond the sort of, day-to-day things is that you need to have good vagal tone, appropriate vagal tone, not hyper, not hypo. A lot of it comes down to the vagus nerve in the neck and in the around the diaphragm. So I'll mention that as well. So firstly, the vagus nerve runs through a thing called the carotid sheath alongside here in the neck. And that sheath is going to be where a lot of the problems start for POTS patients. And postural hypertension as well, because a lot of those are hypervagal types. And what happens is that the vagus nerve gets compressed there, often attributed to either some kind of structural change. It might be this is not common, but some patients, it's a tumor, it's a goiter, it's an enlarged lymph node, it's something structurally pushing on the nerve, and that's enough to cause it. They have a tendency to be one-sided problem, not both, obviously. Whereas most are actually to do with another phenomenon called cervical instability. Now, you don't have to have ehlers-danlos syndrome or hypermobility syndrome to get this. You can just have developed it from a whiplash injury or from sedentary lifestyle. Cervical instability is not uncommon. In fact, there are varying degrees of cervical instability, and it doesn't require a high level of cervical instability, whether it's upper or mid or lower, to cause the problem. And the way that it works is that if a vertebrae moves in a way that's not correct, it moves, it slides, it rotates when you are moving normally, and it shouldn't be doing these actions, right? These are the things that are termed instability. It can make your muscles guard and contract in a way that is beyond what they should. And that contraction, particularly in the front of the neck, can literally strangle the vagus nerve. And it's enough. It's enough. The unfortunate thing is, as that sternocleidomastoid crosses, the muscle at the front here crosses over that vagus nerve, and if it contracts, you often don't feel it, by the way. You often don't feel it. If it contracts to stabilize your neck, and your vertebrae and your intrinsic muscles deeper as well contract, and they all crush that nerve, you're going to get symptoms. And I find it quite phenomenal. Like, people who have this problem often will find they put strapping on their neck, they put a brace on their neck, some kind of thing that prevents it, or eye traction their neck, or I compress, some kind of change in their neck stability is achieved. Their POT symptoms simply disappear. And it throws away a lot of the other research, So, like, if you've got these people who have blood pooling in their legs and they believe it's to do with nerve damage, often they'll say it's viral, they'll say it's COVID, all sorts of things they'll say. But I traction the neck, or I put stabilization things into the system and change the way the neck's behaving, and that heart rate is not changing now. It's going up a little bit, but not abnormally. That is a key indicator that it's starting in the neck. And if you waste your time trying to resolve some other problem that doesn't exist, because medicine has decided to ignore cervical instability as a cause, because one of the reasons they do that, the way they do that, is they don't have good parameters of what is cervical instability. They don't know how to determine the level of cervical instability required to cause symptoms. Whereas clinically, I see you can test this very easily by just changing the position of the neck, and in lots of different ways, of which I do. There's quite a complicated procedure. And you'll find that, by and large, many of these cases, their heart rate doesn't change anymore. So you don't have POTS at that point. So what we do is do everything to kind of normalize that neck function. We improve the nerve mobility. We make sure there's good voltage in that nerve. There's a variety of ways in which that can be done. We're going to make sure that nerve is healing. And if it's damaged, we're going to start healing it. There's lots of ways of which you can promote healing in nerves under the banner of neuromodulation, shockwave therapy, even ultrasound therapy has been linked to changes there, light therapy. Even electroacupuncture has some evidence, and there's lots of herbs that have been linked too. But neck stability appears to be the thing that determines someone's long-term outcome. So I do a lot of work now with stabilization of the neck, stabilization of all the muscles of the neck, and of the upper thoracic and scapular region. Once all these things are working a lot better, people have less symptoms, by and large. And there are other cases where this doesn't work, and often that's because of some kind of obstruction. The other type that you see sometimes, which is not as common, is hiatal hernias. Now, hiatal hernias are far more likely in hypermobile cases, but that's where you've got a bit of the stomach going up the hiatal, or the hiatus of the diaphragm, and in that space is also the vagus nerve. You look up, if you Google hiatal hernia, you'll see photos of this, and the vagus nerve can get crushed. So a lot of those cases actually have a thing called phrenic nerve neuropathy, and that's a different neuropathy and nerve damage that needs to be rectified. But that's another case of, if you know how to deal with nerves and help them repair and normalize their function, you can get to that. And cervical instability can cause that too. So the cervical instability seems to be, in many, many cases, the underlying cause. And you might ask, why is it this? Why is this our Achilles heel? Well, sedentary lifestyle is probably a big factor. Neck diameter is a determining factor of how unstable it's going to be. So the thicker your neck, the less likely you are to have instability. And we do lose a lot of muscle in our neck, unfortunately. Neck pain and headaches are a very common symptom. And how many people have these symptoms, and it could actually be attributed to instability? Unfortunately, manipulation, particularly high velocity manipulation, may not be appropriate. And a lot of people will feel the need to get that. So my opinion is you've got to do low velocity type corrections if you're going to. But overall, you need to start rehabilitating the neck, strengthening all muscles, not just the intrinsics. It's a very important thing. A lot of people think you've got to do multifidi rotatories and longus colli capitis, and that's all. The truth is that stability is provided by all muscles in different ways. So you need a holistic strengthening plan. So the idea of today is to alert people to the fact that there are other reasons for their symptoms. It's not just going to be there's some kind of viral mythological creature that is harming them in the shadows that they can't see. In fact, the likelihood is it is mechanical. It is mechanical reasons like cervical instability or other. There are other conditions that I haven't mentioned, like Chiari malformation and some severe upper cervical instabilities that can actually be very difficult to treat, but can actually resolve with strengthening too. You need a really good clinician that knows how to rehabilitate the neck with a slow, progressive approach. And the diaphragm may be a key component of it because of the phrenic nerve and how the phrenic nerve may be impacted by the cervical instability. So there's lots to talk about, but I'm going to do some more podcasts soon on POTS and the research and discuss that with one of my family members and good friend, my cousin Anna Goldsworthy. And they'll be coming up soon. And on those podcasts, we will discuss the evidence and try to, weed out these theories that are coming in that actually don't provide any answers. They actually misdirect people. And I think for those that are living with POTS, you want answers. You don't want more confusion and more drugs. So just be careful out there. The key is to work on something that is going to achieve a cure rather than something that's just going to prolong the condition and relieve symptoms, and that's it. Okay? I hope you enjoyed today's podcast. I hope you got something out of it, and I'll see you next time.